नमस्तुभ्यं वरदे कामरूपिणी विद्यारम्भं करिष्यामि सिद्धिर्भवतु मे सदा पद्मपत्रविशालाक्षी पद्मकेसरवर्णिनी नित्यं पद्मालयां देवी सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Hi, good evening, everyone. Thank you, everyone, for coming in today for this session of the Executive Committee meeting. So I'd like to invite Divya Malikarjun. Dr. Divya, can you come on screen, please?
Yeah, hi. Hello, everyone.
Hi, so Divya, Dr. Divya is an associate professor of cardiothoracic surgery here at Jayadeva Hospital along with me. And she has done a fellowship, an observership at Boston Children's Hospital and a fellowship in congenital cardiac surgery at Westmead, Australia. So we both are here to present a couple of interesting cases today. So I'll start that. All right. So the first case is a 47-year-old who went to a nursing home at Hyderabad for shortness of breath. He had those complaints for 2 weeks. On echo, they found an IBS mass and referred to a tertiary hospital. In the tertiary hospital, a CT scan was done, and then a surgery was suggested, an immediate surgery was suggested. But they got discharged and came here for an opinion to Jayadeva Hospital. Here, a cardiac MRI was requested for further characterizations. And at the time of cardiac MRI, CT images could not be retrieved and they had not got their images with them. There was a past history of stents to the LCX in 2020. At the coronary angiogram had shown a single vessel disease in the RCA and a patent stent in the LCX when it was done at the time of admission. Previous 3 echocardiography studies had not mentioned anything about the intraventricular mass, except for so it was incidentally found on the echocardiography done at his time of admission. All right, so going into the cardiac, just 1 second. Sorry, I'm just going to share my screen again. So this is the MRI study of this patient. So this is the Hayes axial, and you can see that there is a lesion in the septum, in the interventricular septum. And I'll play the axial cine. The lesion is heterogeneously hyperintense compared to the myocardium. The ventricular function is mildly depressed qualitatively. There's not much MR or TR, and the RV function was normal. Looking at the coronal cine now. So this is the interventricular septum here, and you can see the mass, which is kind of expanding the interventricular septum thinning it and expanding the interventricular septum with some hyperintense areas within it. You could see the aortic valve there and there was no AR. So coming to the 4-chamber view, this is the IVC here, the right atrium. So there's a part of the mass which is bulging into the right atrium. And although it's occupying the septum, there's more of the mass bulging into on the right side than on the left. So this is the 3-chamber view. So when you actually open up the aortic valve as well as the mitral valve, you don't really see the mass. It's more towards the tricuspid valve. This is the LVOT view. And here you can see the mass in the interventricular septum, which is heterogeneously hyperintense on this cine SSFP. And this is the STIR images. And you can see that the mass appears lobulated, well-defined, and quite homogeneously hyperintense, and is expanding the interventricular septum and thinning it both subendocardially as well as on the RV side of the septum, and almost reaching the subepicardium here. To show you the location of the mass on the short axis, going from the apex to the base. So here you can see the interventricular mass. So it's located in the inferoseptum and going towards the anteroseptum. It also extends a bit into the inferior wall. And that was the tricuspid valve there. And you can see the bulge into the right atrium. Okay, so here is the T1. On the T1 weighted images, the mass is heterogeneous, ISO to hyperintense, predominantly hyperintense. So on the T1 fat suppressed images, you can see that it's not suppressed, remains hyperintense. Okay, so this is the dynamic first pass perfusion images. And what you see is that the lesion per se does not perfuse. There is some capsular enhancement, which is probably the the thinned out interventricular septum. So this is the early long TI that we've done. And here you can see that the lesion remains hypointense with some amount of peripheral enhancement. On the PSIR sequences, you can see the peripheral enhancement, the well-defined lesion, and the extent of the lesion. So when we go from the base to the apex, we see that the lesions extending is predominantly, the epicenter is in the basal to mid inferoseptum, and it's extending into the inferior wall, occupying the space of the inferior hinge point, and extending a little bit into the anteroseptum. And it's well-defined, peripherally enhancing. And as we go towards the mid, this is the level of the papillary muscle. So as we go towards the mid, there is a part of the subendocardium which gets spared in the anteroseptum, and probably even towards the apex, the subendocardium remains spared. And there's no RV enhancement, and the rest of the ventricle is also not enhancing. So to show you the other views, here's the 4-chamber view. showing the lesion. There's a small septation here, but otherwise it's peripherally enhancing. And the two-chamber view. So you can see the lesion well. And this is the three-chamber view. All right. So with this in mind, I'd like to ask what would be the differentials that you would think of if anyone wants to. So this is what we found: iso to hyperintense on and heterogeneous on T1 weighted sequence. On T1 FAT-SAT, there was no fat suppression. On STIR, it was hyperintense homogeneously. And on the first pass perfusion, there was no perfusion. And on early and late long TI, it remained hypointense. And delayed enhancement showed a peripheral intense enhancement, and rest of the myocardium was normal. So with this in mind, I'd like to find out what you all think about this lesion.
Could it be a posterior intraventricular septal hematoma, Ashita?
Yeah, so sorry. So yeah, that's a good thought. So the differential that I thought of were whether this is an RCA, because the lesion, the coronary angiogram had shown an RCA territory, an RCA, significant RCA lesion, an LCX which was stented. So whether it was an RCA territory infarct with an intramyocardial hematoma, or a cystic lesion in the IVS with hemorrhage with no infarction. So how many of you would go with one, and how many of you would go with two? Or is there any other differential that you could think of? Because these are the only two things that I thought of.
What about lymphangioma?
Sorry?
Lymphangioma?
Lymphangioma. Yeah, so that comes under a cystic lesion. I didn't think about a lymphangioma, but I did think that it could be any cystic lesion with a hemorrhage within.
Could be a pseudoaneurysm.
Let me go back.
Into the myocardium.
It was not communicating with the cavity at all.
It's not okay.
There was a very good margin from the lesion and the cavity. It looked like the septum was expanded by the lesion, and it was a lobulated lesion with where either capsulated, well encapsulated, or very well defined. And
go with
You are
one.
telling RCA infarct, but it is not in the RCA territory, no?
So so basically the epicenter was in the inferoseptum. It was extending for a bit into the anteroseptum and into the inferior wall. So I could only relate it to that in the sense that I didn't have any other differential. So my first was probably, I've just written it like this, but then I was thinking of a cystic lesion in the IVS with hemorrhage over an RCA territory infarct, but I wasn't sure at first like how to differentiate both. But one of the things that I thought was going against an RCA territory infarct was, like you said, it was extending even into the anteroseptum, which very unlikely that an RCA infarct does that, unless it's a super dominant RCA. And the other thing is, I thought that the subendocardium at places was actually spared, and it was more of a mid-septal, like it was something that was occupying the septum rather than arising from the subendocardium, and no other part of the inferior wall or RCA territory was involved. So that was my thought. Any other thoughts? Because I thought this was a very interesting case, and we actually took some time to come to this diagnosis.
Fibroma?
Sorry?
Can it be a fibroma?
But the delayed enhancement did not show. Usually a fibroma would show some avid enhancement. Yes, atypical fibromas needn't, but then the delayed enhancement generally, because of fibrous tissue, would show avid enhancement in a fibroma. And this patient was how old was he? Divya, how old was he? I don't know if wrote that. 47-year-old, yeah. 47-year-old patient. So fibromas are very rare and it's more of a childhood mass. So I'll go to the next. So basically, we did not have the CT scan with us at the time of, doing the MRI, but somehow we retrieved the CT scan, and here it is. I'll show you. What it showed. So other than the stent in the LCX and some calcification in the LAD, you can see the cystic lesion, which had some peripheral specks of calcification.
Hydatid.
Yeah, so with this, we were like, there's no other differential. So we called it a hydatid cyst. Let me just go here. So so the MRI report of ours read this. It was a normal ventricular size with moderately depressed systolic function and a normal right ventricular size with borderline depressed systolic function. There was a large, well-encapsulated lobulated cystic lesion with hemorrhage within and a peripheral calcification with CT, which was seen on CT. So this suggested a hydatid cyst with hemorrhage within. Other differentials included a chronic organized, collection complicated with bleed within, because no one wanted to believe that this could be a hydatid cyst, since we had a lot of MDTs about this case, and because this was not picked up on any other echocardiography. And he's had like serial echocardiography since his stenting in 2020. And this was in 2021 also he had presented with VT. And this is in 2022 that he had another echocardiography, and incidentally it was picked up. So they were like, hydatid cyst does not really, fit with the explanation. So we thought that the bleed within the lesion could explain the sudden increase in size. So this is what we did.
Ashita, why are you thinking of hemorrhage? Can it be proteinaceous fluid?
Yes, so you're absolutely right. So at that point in time, we did not think it could be proteinaceous fluid because it appeared hypointense on the long TI sequence. And for me, hypointense within the lesion in a long TI sequence, I felt like probably it was bleed related rather than just proteinaceous material. So probably that it bled within, or if it was proteinaceous material, which I did not think of at that point in time, probably because of secondary infection, it could have increased in size, and it would have probably been much smaller and not diagnosed on previous echocardiographies.
Do hydatids bleed?
You can have hemorrhage within the hydatid cyst, yes. So we looked at a lot of literature when we did this case. So yes, it can have bleed within.
It is not actually bleed. It might be some floating membrane, something like that, proteinaceous.
Yeah.
Very rarely it can bleed.
So, so here are the surgical images. Divya, I request Divya to take over here.
Yeah,
so this
hi.
is basically a discussion for us to understand what they also did intraoperatively.
So this seemed like a very interesting case to us because it said it presented from the interventricular septum. So we weren't entirely sure what our approach was going to be. So what you see the first video running here is when the patient is already on cardiopulmonary bypass and we've given cardioplegia to arrest the heart. So what we're actually doing now is trying to open the right atrium. So now we've just held the RA wall between the forceps, and now with the scissor, we are actually incising the RA to enter into the RA cavity. So even if our approach was going to be through the RV, we would have had to enter the RA and then through the tricuspid gone into the RV. However, yeah, I'm just going to let the video run and just talk to you as it goes. Yeah, this is the RA which has already been opened. Now we've just taken stay sutures on the RA wall to give us a little bit of better exposure. So now what you can see is the sucker which is there in the RA wall. We're trying to define the mass. The bulge that you see, I think Ashita is trying to point it out, is actually the cystic mass which is protruding through the floor of the RA itself. So what we did first, what we saw, the saline which we instilled into the operating field is actually hypertonic saline. After flooding the field with hypertonic saline, we have also injected the cyst with hypertonic saline. I know the video will not probably suggest it. I think this video can be paused and we can just go to the next one.
Okay.
Yeah. Yeah. So most of our experience with hydatid cyst is actually very limited. From the time I've been here, I think this is just the first case I have seen. And in our unit, my chief said this is probably just the second case that he's done in about 25, 30 years of experience. So most of how we tried to manage the case had to do a lot with our literature research. So literature, based on that, we've injected hypertonic saline into the cyst wall. And like I said, the video does not suggest, but we actually had to wait for about 20 minutes for this colicidal action to take place. So then we've actually packed the rest of the field with gauze to prevent any spillage if there was, because we didn't know what we were entering. So what we are doing right now is actually entering into the cyst itself. So this is basically the pericyst. It had an extremely thick wall. So as you can see, despite having made that incision, we still haven't entered into the cyst. We're still trying to create a plane to try and enter into the cyst cavity. So once this has been, so we were trying to see if it's possible to identify if there's an exoskeleton which we can take out. But when we see the video, we'll see that it wasn't actually possible for us. So we're still trying to extend the pericyst incision. Yeah, we can go to the next one. Yeah, so after that, what we did was on the cyst wall, we took a couple of stay sutures after removing the first layer. I know the video seems like a very fast edit, but it was a very tedious process, which took a really long time. I didn't want to take up so much of your time. So we've taken actually stay sutures on the cyst wall, then entered into the cyst. And after that, we actually gave a thorough wash with metronidazole into the cyst cavity itself. After that, what we did was, before we did the metronidazole, we actually aspirated some amount of purulent material which came out. Subsequently, the test turned out to be negative. There was nothing which grew from the cultures of that. So as you can see now, the cyst wall has been entered. We're excising part of the cyst and we've tried to remove as much of the cyst cavity as possible. So after we emptied the contents of the cyst, we didn't want to remove the cyst completely because of its attachment to the interventricular septum. Because for us, the biggest fear was in our attempt to give that complete clearance, we didn't want to create a VSD. That would have been more detrimental to the outcome. So what we did was we decided that we'll completely obliterate the cavity. So we have taken multiple purse string kind of sutures from the apex of the cyst, and we've come up to the surface of the pericyst, all the while obliterating the cavity. And then once we came up to the surface, we have closed the pericyst completely. Yeah, the video's done, Ashita.
Yeah.
So yeah, so we closed off the pericyst and then we gave a wash again in the RA cavity and closed the RA, and then subsequently came off bypass and everything.
Yeah, thanks,
Yeah.
Divya.
Yeah.
I found this video like super interesting. I found the surgical procedure super interesting, so that I asked Divya to like share it with all of you. So what we found on pathology is the hooklets in the hydatid sand, and it confirmed that it was actually an intraventricular septum hydatid cyst. So basically the discussion is, for me, the learning point in this case was that, first of all, the intraoperating finding was that there was no blood. Like you all rightly said, it probably was that purulent proteinaceous material and not blood that was within the cyst. And that would have caused the T1, the hypointensity on the long TI imaging. And there were no daughter cysts, and there was some purulent material within the cyst. So highly proteinaceous contents may have caused the T1 and T2 brightness. And the infection of the hydatid may have led to that sudden increase, which might have gotten picked up by that particular echocardiography. And the delayed enhanced CMR, as we all know, at 600 milliseconds, is selectively used to null avascular tissue and not such as thrombus and not just thrombus. So everything that looks black on long TI needn't be a thrombus. So this was one case. So the second case is a case of a 51-year-old male who was a known case of renal disease, who was diagnosed to have coronary artery disease and was on medication. He presented with monomorphic VT and was diagnosed to have IHT with an anterior wall, inferior wall, as well as a posterior wall MI in 2019. In 2021, they did a coronary angiogram, which showed a 70% lesion in LAD and a 70% lesion in the RCA. This was what the report said. So, and the echocardiography showed an LV apical aneurysm involving the mid and apical septal, apex, mid and apical anterior, apical inferior, and apical lateral segments, which were thin and akinetic. The patient had a grade 1 MR and the PASP was 220 and the EF was 36%. The CMR was asked for assessment of the VT. So I will show the CMR, but we've also done the post-op. So at the time of surgery, after the CMR, the coronary angiogram at our hospital did not show any significant disease, and it was only 30 to 40% in the LAD with some mild plaquing in the RCA. And it was referred for surgery. A DOS procedure was done in November. And the echocardiography post-DOS procedure was showing an EF of 41% and post-DOS status and changes. So let me show you both the cardiac MRIs. So this is the pre-op. All right. So this is the pre-op two-chamber view, which shows a large apical aneurysm, which is arising from the apical segments that's involving both the apical true apex and then the apical inferior segment. I'll show you the short axis views to show you where exactly it's arising from, but it's going and indenting on the diaphragm like you can see. So this is the post-op. And you can see the reduction in the size of the apical aneurysm. This is the apical aneurysm, part of the apex, true apex that's been left behind. This is the apical, obliterated apical aneurysm cavity. So they've cut off quite a bit of the apical aneurysm, and this is what's remaining there in order for them to have space to suture. So here, I'll show you the 4-chamber. So here you can see the pre-op images, and you can see that the patient is in bigeminy. And otherwise, the contraction seems pretty good. The LV function seems well preserved, other than the apical aneurysm. This is the level of the papillary muscles. So insertion. So basically, you know that this is or everything is from the apex. And post-operatively, you can see what changes are there. We did this as an academic, for academic reasons, the post-op, to look at the changes and to look at the restoration of the ventricular morphology post-op. You can see the area of the patch And this is the aneurysm cavity, and this is the region of the patch. There's some slow flow of blood within that residual aneurysm cavity. Here is the 3-chamber. So the pre-op, you can see the thrombus here along the wall. And on the post-op, again, you can see that small communication in the region of the porous patch that they put to exclude the aneurysm. And this is the almost obliterated aneurysm cavity and the residual ventricular cavity. So here's the short axis. So this is the pre-op short axis. You can see the large aneurysm here. So you can see that it's arising from the apical inferior and involving part of the apical lateral and the apical septal and the true apex. And this is the apical anterior, which is hypokinetic, but thickness is maintained. And from the mid, this is the level of the papillary muscles that you can see. From the mid, it's pretty good. Here you can see the postoperative changes in the apex with a lot of inflammation and thickening. And this is the residual aneurysm. And now it's just immediate post-op. So there's a little bit of global hypokinesia. So on the delayed enhancement, so you can see on the delayed enhancement pre-op that there was some thrombus here, and the whole apex is enhancing the aneurysm and aneurysmal wall, and the anterior apical anterior wall is spared. This is the septum, lateral wall, inferior wall are all enhancing, and the mid is again spared and it's good, and the basal also doesn't have any influx. Do you want to see any other images? Any of you want to see any other images? I can go to the slides then. Okay. Can you see my screen? Can you see my screen?
Yes.
Yeah.
Yeah, we
Yes,
can see.
yes.
Yeah.
Yeah.
So that was the finding on cardiac MRI. So the preoperative scan was done in October 2022, and that time the EF was 20%, along with when we included the aneurysm, and we had an end diastolic volume index of 232 and an end systolic volume index of 187, and excluding the aneurysm, the end diastolic volume was 111. And the end systolic volume index was 66, which comes almost within normal limits. And so we gave the interpretation that it was a severely dilated left ventricle, which obviously included the aneurysm, and severely depressed systolic function, and excluding the aneurysm would reduce the EDV to near normal. And there was normal right ventricular size and systolic function. And So basically we gave that as either a distal LAD or RCA territory infarct, which involved 3 to 4 of 17 segments. That is the apical inferior part of lateral septal as well as the true apex. And it was non-viable with a large apical aneurysm and mural thrombus within. So this patient underwent Dawes procedure, and as you could see the postoperative, on the postoperative images, the EF was 22%, and the EDVI had reduced to 132, and the ESVI had reduced to 103. And the patient had all those changes that we saw post-operatively, which also included a residual LV apical aneurysm with a sliver of thrombus and slow filling and flow in the residual excluded LV apical aneurysmal sac, was all a part of post-Dawes normal appearance. So here is the Dawes procedure that I'd like you to see the video of. Divya, you can take over.
Yeah.
1 sec, I'll just start playing from the beginning.
Yeah. So this
Yeah.
again is a patient who's already on cardiopulmonary bypass with an arrested heart. So most of the time when we're doing the DAW, our approach is through the aneurysm itself, the incision. I know it seems like butchery, but whatever we're cutting off is actually all the dead tissue or the aneurysmal tissue. And at the end of it, you'll realize that we've taken off so much of the aneurysmal tissue, and still, if you can see on the MRI, it still seems that we've left behind some. So what we have done now is actually excised completely, or as much as possible, the aneurysmal portion. And now when the heart drops down, you'll realize that it's now looking normal. Once we cut off that last bit. Yeah, so now you see how it's sitting in the heart cavity. So that's the actual size of it. So now we've just held up the margins of the aneurysm or the LV to have a look inside. So that's the end of the video. You can go to the next slide. So I just want to tell you a little bit of how we do this procedure. So once we actually enter into the aneurysm, in this case, since the aneurysm itself was so huge, we had to resect quite a bit of it. So the procedure may be done either with or without resecting it. Since this was such a huge one, we've done that. Next, what we need to do is actually separate the mouth of the aneurysm from the LV cavity. So before we do that, the mouth will usually be a little bit smaller. Our aim is to reduce the communication size to a diameter of about 2.5 centimeters. So to achieve that, what we actually do is take a purse string suture at the junction of the viable and the non-viable myocardium. So after we take a purse string, this is what we call a Fontan stitch. So after we take that purse string suture, we reduce the mouth opening to about 2.5 centimeter. After that, what you can see here is the Gore-Tex patch, which we are trying to suture to the margin. So we suture that. Once that suture line is completed, that's how it looks like the image on the right. So this now has separated the LV cavity from the aneurysmal cavity. Our aim at the end of DAWs is to have the LV end systolic volume indexed at about 60 to 70 ml per meter square. We usually have a balloon which is fashioned through which we can actually measure the size of the LV cavity we are leaving behind. And using that as a guide, we take the purse string to reduce the size of the LV volume to that much. Can we go to the next slide? Yeah. So once the patch is closed, what we now do is approximate the two ends of the aneurysm or the incision line. And because it's a thinned out cavity or a thinned wall, to help us achieve good hemostasis, we actually use what we call the felt, the PTFE felt patch on either side of the incision. And we take full thickness sutures to complete the suture line. Yeah, so that's how the DAW is done.
Thanks, Divya.
Yeah.
So basically the goal of DAWs is to restore LV geometry and to reduce the end systolic volume by at least 20 to 30%, ideally 60 to 70 ml per meter square, or at least below 90 ESVI. If a pre-op ESVI is more than 120 ml per meter square, then the 5-year mortality is higher. So, I mean, doing it when the pre-op ESVI is lesser itself would make the prognosis much better for the patient. So just to give a little bit information about the use of cardiac MRI in surgical ventricular restoration. So these are the several specific questions that arise in the selection and surgical planning process. One is the measurement of the asynergic or the non-contracting area of the scar, which is the nidus of the remote dilatation, the adequacy of that is the aneurysm in this case, and the infarct. So, and the adequacy of the remote muscle to compensate after the scar is excluded. So how much of the remote myocardium is viable and is healthy? And the ventricular end systolic volume, which is the surrogate for increased mortality after infarction, the viability of both the surgical target region and the remote muscle, and mitral annular dilatation after ventricular stretch, and the width between papillary muscle, that is the interpapillary distance, that can change and impair leaflet coaptation. So why CMR? All of us know why CMR. So basically, it allows for selection of appropriate patients for SVR and improved planning for all potential associated surgical interventions in the same examination. So how would all this matter? So extent of asynergic myocardium, status of the remote myocardium, and the LV volume, and the presence of absence of viability will determine the LV systolic function. And the mitral annular size and papillary muscle base width will correlates with the preoperative mitral regurgitation and its likelihood to occur postoperatively. So MRI is better than echo in this because it potentially it leads to information that may not be seen on echo very well, such as the annular dilatation, which can be remedied by annuloplasty, or the LV dilatation, which can be remedied by SVR, or the papillary muscle spacing, which can be treated by placement of slings or reapproximate the papillary muscle, making the evaluation of these factors vital in surgical planning. So conclusion is that cardiac MRI has been a major contributor to the overall success of SVR. The ability to the technique to provide optimal preoperative information depends on the establishment of clearly defined measured parameters, effective communication between the interpreting imaging physician and the surgeon, and ability of the surgeon to incorporate this information in formulating an appropriate comprehensive surgical strategy. Thank you. We're done.
Ashita, thank you very much. Can I ask you a couple of questions, please?
Yes, please.
Can you show us how you do the mitral annular dimension calculation and the mitral valve distance as well? These are two parameters which we don't tend to give for our DORS patient, but that might be something new to learn and understand.
Sure. So, you know, what's in the literature is actually the mitral annular dimension, the largest mitral annular dimension on a true 4-chamber view. Okay, so basically we take the true 4-chamber view, take the maximum distance, and then measure it on one sec. Yeah. So you find the annulus and then measure it on a true 4-chamber view. So what I also do is I look at the 3-chamber view and again get the biggest and then measure it.
Ashita, are you trying to show something? We are not seeing anything.
Oh, you're not?
No.
Oh, okay. Let me share again. Sorry. Sorry, I didn't know I was not sharing my screen. Right. Yeah. So on the 3-chamber view, we basically take the, you know, the largest dimension, and this is how I measure it. And then on the 4-chamber view, so the dimension is based on the 4-chamber view. So if it is more than 27 mm, it's dilated. So there is more chances of postoperative MR in such patients if it's not corrected. So this is 30 millimeters. So
Should we
take the
measure in
micro-
end systole?
This is so this is basically when the valve is open. It's not an end
Open,
system.
okay. Okay.
It's open. So the largest dimension of the annulus. One sec. And the interpapillary distance is on the short axis view. So you take the mid ventricle level in the short axis view in diastole, and then take it from the mid papillary muscle to the mid of the anterolateral, mid of the posteromedial to the mid of the anterolateral. 27 mm is the cutoff for both the mitral valve as well as the papillary muscle, and here it's 34 mm. So it is dilated. If it's not this dilated, so even if it is not too dilated, like in this case, it's somewhere borderline, like 34 mm, when 27 mm is the cutoff. So probably when they do the purse string suture, it will anyway approximate. So surgeons, I'm not sure. Divya, what is your take on this? When we give you the mitral annular dimension as well as the interpapillary distance.
It becomes significant in us for the reading when on an echo we have significant MR. On that, if you're not having significant MR, we just actually leave it alone. Because doing a mitral valve repair, when, as in like, because the chances, especially in an infarcted heart, when we take sutures at the papillary muscle also, the chances of it giving way or tearing are much higher. So if it's not causing significant volume overload because of MR, we don't do anything.
I hope that answers the question.
Yeah, Ashita, thank you. If others don't have any comments, I'd like to make a comment in the end, but I'll leave others to ask any questions.
Anyone else?
So I just wanted to say that we have been working a lot. Dr. P.V. Rao was one of the pioneers of DORS procedure, and we've been working a lot. Of course, this is one very classical case where you've got such a large aneurysm, but many a times it's not that big, and it's just the LAD territory large infarct where we do quite a few DORs in there. So if it comes across for anyone, one of the things people have to realize is whether the septum is infarcted or not. That becomes a very, very important parameter. If the septum is infarcted, then the surgeon needs to know about it, because then approach and maybe the pericardial patch has to be changed a little bit. Post DORS, when you do the MR, be very, very careful, because some of the excluded aneurysmal sac can be confused as a thrombus within the LV cavity. That's something one has to be very careful about, especially when you're doing it for a simple LAD territory infarct DORS. We've had some infarcts of RCA, so inferior wall aneurysms also we've tried to repair. That is usually not a great surgery. Its access is very difficult for people. But otherwise, when you have large LAD territory infarct, remember, apart from what Ashita has just said, remember to mention about septum, whether the septum is involved or not. Second, look for the in post-operative cases of DORS, when you do follow up, don't call things as thrombus, because they may be just exteriorized sac.
Thanks, Vimal. Anyone else? Any comments about the cases that I've shown?
Just, I could not contribute to the first case of Hydatid. Very, very nice case. I think we've had one case which we have shared between CMC and us, where there were Hydatids within the right ventricle, but the presentation was pulmonary embolism. And
wow.
the hydatid cysts had basically embolized. And then when we started looking for causes of pulmonary embolism, and then we figured out they were hydatid cysts within the RV cavity. So, but not as big as this, obviously. This is quite huge. So very nice cases, Ashrita. Thank you.
Thank you. Have any of you seen hydatid cysts causing constrictive pericarditis?
See,
Because of mass
even I
lesion
have
or-
come across, I have come across two cases almost 15 years back. So they were in the RV free wall, not in the interventricular septum or in the remote area. So those things were operated very nicely without going for the bypass. It is done at the Vikram Hospital, Mysore by Nagendra Prakash and Shanaik. Two cases consequently within a matter of 15 days, two cases we had, and they did well. Only we have done the CT, not the MR examination. It is in 2007 or 8 like that.
Actually, we've seen free wall hydatid cysts, but this was my first case of our first case, the team in Jaideva's of interventricular septum being involved. But there are quite a few case reports about the interventricular septum hydatid cyst.
I have a question here. How common is calcification in a hydatid cyst in the heart? Because usually the hydatids in lung don't tend to calcify because of the pulsations of the heart. It's the explanation that they give.
So
But here it
here,
is inside the heart, but there is
yeah.
still a calcification.
It's an interesting question because I don't know how common it is, but the clincher for me was the calcification on CT.
Yeah, that's what. Yeah, calcification does let us to think about hydatid. Maybe it's complicated with some infection. That's why it got calcified. Maybe that could be an explanation. Otherwise, hydatids in chest, they rarely tend to calcify because of the pulsations of the heart. That's what they say. Yeah.
Anyone else would have given this as hydatid cyst even if there was no CT?
I would not have.
I have exactly the same case, but that's a CT and MR combination, exactly same location, exactly same things. This had come to us about 5 years ago. But I think as a standard, any mass, we just do CT, whatever mass it is. It's just easy to look for calcification. So that scenario would not have come. But Ashita, you were saying constriction with pericardial, with the cyst.
Yeah, so we know hydatid cysts can present with acute pericarditis, but then whether any of you have seen, it develop into a constrictive pericarditis, patient presenting with constrictive pericarditis secondary to a pericardial hydatid cyst.
Not seen that, no.
I think I have a case today. We just had a look at it this morning. So I was reading up the literature. There are few case reports on constrictive pericarditis, hydatid cyst leading to constrictive pericarditis. I'm yet to read it up to before I report the case tomorrow. Anyway, interesting discussion. Thank you very much, all of you, for attending. And thanks, Divya, for taking off time and giving us your expertise on the surgical aspect of both cases. Thanks so much.
Thank you. Yeah, thanks. It was a very interesting discussion for me as well. So thank you very much to everyone for having me here.
Is everyone there?
Yeah. Okay. See you, Ashita.
Yeah.
Thank you very much.
Thanks.
Thanks.
Bye.
Thank you, Ashita.
Thank you. Bye.
Bye-bye.
Thanks, Ashita. Nice discussion.
Bye, everyone.
Bye.